Hi, I'm Dr. Pavol Vesely, and in the first episode of the series, we just talked about communication with the patient to achieve optimal refractive surgery outcome.
Hi, I'm Dr. Robert Ang, and in this next installment, we're going to take a look at what treatment options we, as refractive surgeons, have in our arsenal, all to make sure patients walk out of our clinic with crisp, clear vision that they demand from us. LASIK has been with us forever. We need to describe that to the patient that there's part 1, which is cutting the flap part, and part 2, which is laser ablation or correcting their refractive error. It's a fast procedure, and recovery is the fastest among all the options. So aside from that, we have done LASIK for many patients. So I guess the experience of us combined and with other doctors is the most in literature and experience. That ensures safety, and nomograms are also set, techniques are there. My number one fear or disadvantage of LASIK is ectasia. So ectasia is something more or less more permanent and more disabling. The other things about LASIK that are disadvantage are dry eye, which you can manage, regression, which you can manage. So it's more or less ectasia that needs some explanation to the patient that this can happen. Aside from LASIK, we have so many other refractive options now.
Yes, we do. The biggest group is the LALEX, lenticular extraction, which is gaining very big popularity. I started doing LALEX a year ago, and the results are excellent. Plus, you were mentioning dry eye. You can be a little bit more tolerant to dry eye and still perform the LALEX, while you cannot with the LASIK.
When the patient comes and you screen them, most likely they're qualified for both LASIK and lenticular extraction. The lenticular extraction is more expensive, right, than LASIK. Aside from cost, how do you kind of screen them that, you're more for LASIK or you're more for lenticular, or it's your choice? How's your approach to that?
I'm actually a waiter in the restaurant in this situation. And the patient is the customer who comes and says, well, I would love to have a pasta. Or if he said, I would love to have a pizza, it's choice of the patient. If there is a patient who has no preference, then I can just explain him both procedures and let him make a choice. And if the patient says, what would be your choice? Or please do what you think it's much better, then I would make the decision based on the pre-op exams, and then I would decide, okay, this is the treatment for you. I do think PRK is a still very relevant treatment for our patients.
So in our practice, we've shifted all PRK to trans-epi PRK. So we do a master screening test, and first I check corneal biomechanics or corneal problems, possible ectasia warning signs, and if I see any one of my diagnostics showing that, then they're not for LASIK. So they will be either a PRK or a phakic IOL. So there will be a subset of patients who are suspicious, and I would rather be on the safe side. So you still need your PRK skills with you in your refractive practice. In 2024 now, you see that more and more doctors are adopting this phakic IOL technology. So what patients do you choose them for, and what percentage of your practice is slowly moving into this?
Well, I'm a huge fan of phakic IOLs, to be true. I find it to be excellent technology. It's reversible. That is a great thing. Unfortunately, it's intraocular. That is the second thing. So we are offering the phakic IOLs actually to patients with even 3 diopters, 4 diopters. It's not that we would have a specific group above 8 diopters ICL only. The thing is, many people are scared of intraocular treatment. They rather choose the laser ablation if it's possible.
The phakic IOLs are something new to the patient, right? I mean, very few people come in with that as the first choice in mind.
I want it.
Yeah, I want it. Like, or I know my friend had it and I want it. There are some, but still, laser corneal refractive surgery is number one in their mind when they come in. I think the number one advantage for me of phakic IOL is we spare the cornea and the natural lens because the patients want gratification now, but in the long term, more difficult to calculate lens, aberrations, and all that. So they kind of will pay for it at the long term. But the phakic IOL is you preserve all these structures, you just add the lens. It's exchangeable. We're doing studies on the presbyopic ICL, so we are addressing that age group as well. So disadvantages, well, intraocular, which means that first, there's a skill not to do anything inside the eye. That's bad. Second is the adverse events are a little bit unpredictable. I'm most scared about number one, high IOP the next day, which paralyzes your iris. And number two is inflammation, which kind of messes the anterior chamber up. So I think that's the main disadvantage of ICL. But it's there, and patients are there to choose it. And I think quality of vision is very, very good with the current ICL.
I believe the popularity of the ICLs now can even grow because nowadays diagnostic tools we have, especially the very modern anterior segment OCTs, allow us do a very precise calculation, measure vault of the ICLs, be very predictive, and I believe this is bringing more safeness to the whole treatment and better results, of course.
When a new technology or treatment comes in, first, the doctors have to be proficient, so we have to train them. But the support staff, it's also important. We are so dependent on technology that our technicians have to be taking the correct measurements. So they have to undergo training, but also experience. It's critical to also have a workflow because once you introduce new diagnostics, it makes the screening longer and longer. For me, I like more data to make a good decision. But then, it's the technicians who do more tests, more expense for the clinic, and more time for the patient. So, we do have this process of adapting technologies, and I think your clinic might have that same experience.
Yes, absolutely. We do introduce new technology to our colleagues, doctors, nurses, optometrists. Everyone that is in the house must know what the new technology is doing and how is it doing. So we're learning them how to what is the principle of the technology.
That's all for this episode, and we hope that you've come away with a more complete view of what's out there in refractive surgery. Don't forget to join us in the next time for key tips on preoperative measurements and all the important confluence of patient communication and selection.